You all share lah.
First presenter.
Seminar apa?
Can we start? Virology. Virology.
5 bulan 6. Block 3 ya?
Yes.
Siapa present dulu?
Me.
No.
Nur Aina Izzati. Aina.
Okay.
Okay. Can you guys see my screen?
Yes.
Wait. I have to. Okay. Assalamualaikum warahmatullahi wabarakatuh. We start today's session with Umul Kitab Al-Fatihah. Okay, so my name is Nur Aina Izzati binti Abdul Aziz, and I will start today's virology seminar with the topic of infectious mononucleosis and also Rosella infantum. So this is the content for my presentation for today for both topics. Next, we will start with infectious mononucleosis first. Okay, so what is infectious mononucleosis? It is the best known clinical syndrome caused by Epstein-Barr virus, and it is characterized by a triad of fever, tonsillar pharyngitis, lymphadenopathy, and lymphadenopathy. And it is initially called as glandular fever, but it is also called as the kissing disease because the mode of transmission is through oral secretion. For the etiology, most of the cases are caused by Epstein-Barr virus, which is more than 90% of the cases. And it is a double-stranded DNA virus, which is a member of gamma herpes viruses. And there are also other infectious mononucleosis-like illness that can be caused by other pathogens, such as CMV, hepatitis, and also HIV virus. Next, for the epidemiology, EBV can infect.
Balik semula tadi. Balik semula.
This one?
Apa ni yang last kali ni? 5 to 10% apa?
Which means that 5 to 10% of the infectious mononucleosis like illness, they have like similar presentation.
Not also infectious mononucleosis. Kaya differential diagnosis lah.
It doesn't. But infectious mononucleosis is due to Epstein-Barr.
The symptom can be near similar.
But they do not cause infectious mononucleosis. Just similar.
IFM, there's no such thing of like mononucleosis. You see, the differential diagnosis are because they can give us similar symptoms, but the pathology, the pathophysiologies are different. Next.
Okay, so for the epidemiology, it infects more than 95% of the world's population.
Yeah,
and for the age, it is mainly.
Ada antibody tak? Sure ke?
I took this from.
30% masuk, you all ada berapa? 35, 30 positif lah. Betul tak?
Because
a few positive of infectious EBV virus, iya kah?
I mean, it is usually a disease of it. Most of the cases, if you have primary infection by EBV, if it occurs at a young age, in childhood age, it is usually asymptomatic.
Okay,
so you can only present with a positive antibody titer, but not symptoms of the disease.
Yeah, so
because
we also
it is.
We also positive.
Probably.
Probably pula. You be data dah 95%.
No, I mean like positive antibody titer, but not the disease.
Yeah lah, but we were being infected before lah, all of us by the virus. So if I test you all, 35 of you, 30 will positive, kan? Yeah,
Yes.
positive for the virus, is it? Especially the IgG. Sometimes
Yeah.
IgG dah hilang dah certain time. Cuma yang memory cell je. Continue lah.
Okay, so it is mainly symptomatic diseases of young adults, but it can happen from children to old age, and the peak age is at 15 to 24. And it is important to take note, like what I've said before, it is the disease manifestation is related to the age of acquisition of primary EBV infection, whereby if you acquire it during childhood, it is usually asymptomatic or mild. And if it occurs in young adults or adolescent, it can present as symptoms in infectious mononucleosis. And for the mode of transmission, it is primarily via oral secretions. And since it is one of the herpes virus, it can establish a latent infection. So it can be shed in oral secretion consistently for more than 6 months after acute infection, and then intermittently for life, but in low volume. Okay, next is for the pathogenesis. It starts when there is a person-to-person transmission via salivary secretion to the oral cavity of the other person. Hence, it is called as a kissing disease. And the EBV will come in contact with and it will infect the oropharyngeal epithelial cells. And this will allow the replication of the virus inside the cells. They can also be release of the virus into oropharyngeal secretion, which is the saliva, and they can also infect and replicate in tonsillar B cells because one of the cellular receptor is CD21, and CD21 is present on the B cells. And this replication, it can cause symptoms of pharyngitis. And when there's ongoing viral replication, there will be viremia and dissemination of the infected B cells to the peripheral blood, and also lymphoreticular systems, including the liver, spleen, and lymph node. So there will be lymphocytic infiltration of in the lymphoreticular system that will lead to the signs of this disease, which is hepatosplenomegaly and also lymphadenopathy. The viremia will cause induction of immune response, which include both humoral and also cellular immune response. And for infectious mononucleosis, the main signs and symptoms are usually due to reaction of our immune response. And the first one is for humoral immune response. When the B cells is activated, it will proliferate and it is transformed into plasma cells to produce antibodies. So there are primarily two types of antibodies that will be produced. The first one is antibodies against the specific antigen of the virus, such as viral capsid antigen IgM, which is present in acute infection. And the second one is heterophile antibodies. And these heterophile antibodies is produced by abnormally infiltrated B cells. And heterophile antibodies does not react with the EBV antigen, but it reacts with non-specific cells such as erythrocytes from in mammals. And these heterophile antibodies is used as the basis for serologic tests to screen for infectious mononucleosis through a test called a monospot test. And the second one, for cell-mediated immunity, like any other viral infection, there will be proliferation of T cells, primarily cytotoxic T cells and also NK cells. And these cytotoxic T cells function to control the proliferating B lymphocyte that has been infected by the EBV. And there can also be, there will be a production of inflammatory cytokines, which can cause clinical presentation of fever. Next, like any other herpes virus, EBV can establish a lifelong latent infection, and they persist primarily in memory B cells because they can regulate their immunogenic proteins, and hence they can escape detection by cytotoxic T cells. And reactivation and new replication can occur, but it is usually occurs at a low rate in latently infected cells. Okay, next we move on to clinical features and presentation. Okay, so like I said, the primary infection, it is usually asymptomatic if it occurs in infant and younger children. The incubation period is about 2 to 6 weeks. And after incubation period, there will be a prodromal period that lasts from 1 to 2 weeks, in which the patient might have a history of fatigue, malaise, and myalgia before the onset of fever, sore throat, and also lymphadenopathy. And the characteristic triad that I've mentioned before, which are fever, pharyngitis, and lymphadenopathy. And if the patient is presented with this triad, we need to suspect infectious mononucleosis as one of the differentials. For history taking, the patient, the chief complaint, the patient is usually presented with complaints of sore throat with or without fever, also swollen neck, development of joint pain, and also persistent fatigue. For fever, it is common, and we need to ask about the duration of the fever, because usually it can last for about less than 1 week. And one of the differentials is group A streptococcal infection. And for group A streptococcal, the fever usually lasts for about only 3 days. And there is also symptoms of sore throat, which is often accompanied by a complaint of exudates, which may appear white or green. Patient may also have a presentation of fatigue, and then they can have upper respiratory symptoms such as cough, runny nose, all night fever, and upper respiratory symptoms are more common in viral infection compared to bacterial infection. And then patient can also have headache, decreased appetite, nausea and vomiting, myalgia, abdominal discomfort and pain, mainly due to the hepatosplenomegaly. And patient can also have jaundice, but this one is rare. And other important...
Go back sebelah. Yang gambar tu tak nampak sangat sebab you macam mana nak hilang sebelah ni you all ni. Dia tahu slide tu kan sebelah kanan tu kan muka you all bukan ni slide tu cover. Tak apalah.
I think you can move it to the side.
Macam mana?
Just click on it and like move it.
Musab ke sana pula tutup.
Dan
dia boleh keluar full screen kot.
Tak nak keluar nanti tak nampak apa you all buat. So central nervous system, fatigue, loss appetite, malaise, headache, tonsil, spleen. How many percent spleen enlarged?
About 50%, but it is a late presentation.
Stomach, systemic high fever, cheese stragos, lymph node swollen. Lymph node swollen is more than 90%. Okay, to swab. Okay, okay.
Okay, so other important history that we need to ask include risk factor, which is if the patient has any recent contact with the people who have the same symptoms, including the family members. And we need to ask about the past medical history, such as history of any hematological malignancies, because like acute myeloid leukemia or acute lymphocytic leukemia, which can also be presented with lymphadenopathy and hepatosplenomegaly. And then we need to ask about history of autoimmune diseases such as SLE, because it can also be presented with rash and lymphadenopathy, and any history of congenital or acquired immunodeficiency, because the patients are at risk for severe manifestation of infectious mononucleosis, including chronic viremia. And then we need to ask about developmental history, because if the patient has any developmental delay, because certain congenital infections can lead to developmental delay. And for immunization history, we need to know about the risk of the patient to get any vaccine preventable diseases. And we also need to ask about the drug history, which is if the patient take any antibiotics or anticonvulsants, because they can have infectious mononucleosis like signs and symptoms as side effects. And also usage of corticosteroids, because it is an immunosuppressive drug, so it makes the patient more prone to get infection. And for social history, if the patient spend time in any crowded environment, such as a daycare center, where the infection can spread more easily. Okay, for physical examination, Usually the patient is febrile and the temperature can be about 38 to 39 degrees Celsius. Rarely the patient can appear jaundice. And then also the patient can also appear paler if it is complicated with anemia, which is one of the complications. And then for generalized lymphadenopathy, which is one of the triad, one sign of the triad, and it happens in more than 90% of the cases. And they are typically bilateral and symmetrical and commonly involve the posterior cervical and posterior auricular nodes. And they peak in the first week and gradually subside over the 2 to 3 weeks. The next one is a presentation of pharyngitis and enlarged tonsils, which is also one of the triad, and it occasionally present with exudates. And if the enlarged tonsils is extreme, it can lead to airway obstruction. The next one is a palatal petechiae, which is a small red or purple spot at the junction of hard and soft palate. And this can usually distinguish infectious mononucleosis with other viral pharyngitis, but it does not distinguish infectious mononucleosis from group A streptococcal pharyngitis, which can also present with palatal petechiae. And for the next one is rashes. Patient can also be presented with appearance of rashes, which is usually maculopapular. And patient can also have rashes if he or she is treated with antibiotics such as ampicillin or amoxicillin. For splenomegaly, it occurs in about 50% of the patient, and massive enlargement is not common. And it is a result of lymphocytic infiltration, and it is usually a late presentation of the disease. For hepatomegaly, hepatitis can occur, but it is usually subclinical, which means they can be elevated liver enzyme, but not abdominal symptoms or jaundice. And the last one is presence of edema of the upper eyelids, which is called Hoagland sign. And this is usually without conjunctivitis or inflammation. And this can occur before the presentation of pharyngitis and lymphadenopathy.
Apa nama?
Okay, next.
Apa nama dia tadi? Holland sign.
Hoagland sign. Like in the picture. Okay, so for differential diagnosis, okay, we need to suspect Epstein-Barr virus when an adolescent or young adult complains of sore throat, fever, and malaise, and also has lymphadenopathy and pharyngitis on physical examination. However, there are also certain diseases that can be presented with the same similar signs and symptoms. The first one is infectious mononucleosis-like illnesses due to pathogens such as cytomegalovirus, Toxoplasma gondii, adenovirus, and also acute HIV infection. For this, we need to take note of the presence of any other specific sign and symptoms for our common sign and symptoms in this certain disease. For example, in HIV, the patient is usually presented with mucocutaneous ulceration, but it is not common in infectious mononucleosis. And for cytomegalovirus, the syndrome is similar, but it is often milder, and they have a longer fever compared to EBV infection. However, in most cases, differentiating them is not possible clinically. Thus, we usually do diagnostic tests to look for presence of antibody. The next one is streptococcal pharyngitis. It may cause sore throat and cervical lymphadenopathy, but it is not typically associated with hepatosplenomegaly. Like I said before, the fever in streptococcal infection, it only lasts for about 72 hours. So if it lasts longer, we need to suspect infectious mononucleosis.
How the other way you want to know? How the other way you want to know to differentiate?
I'm sorry? How what?
How the other way we want to know to differentiate?
We can ask.
We start on amoxicillin or Mintin.
If they do not recover.
If you know you did not recover, many ada viral infection. Tapi one thing about infectious mononucleosis, you start antibiotic apa berlaku? Especially the
presence of rash.
Yes, the blue moon or rash, especially the amoxicillin. You start, then rash develop. Then you think slowly the mobily form rash, small rash. Then likely is due to infectious mononucleosis.
Yes.
Okay, lagi. Nombor 3 tu apa?
Number 3 is hematological malignancies, especially in patient presented with lymphadenopathy and hepatosplenomegaly. And the fourth one is it can be due to drug induced, which can be presented with the same symptoms, including drugs such as anticonvulsants, such as phenytoin, and antibiotics such as isoniazid. Okay, next, this is a table of differential diagnosis and their key distinguishing features, which you can read later. Most of it I have mentioned before. Okay, for investigation, we can make a presumptive diagnosis of infectious mononucleosis by the presence of classical clinical symptoms, but the diagnosis is usually confirmed by serological testing. Either we look for the heterophile antibodies or EBV antigen-specific antibodies. So if we do full blood count, there can be presence of leukocytosis, which is mainly lymphocytes, and there can also be mild thrombocytopenia. And liver function test, they can show elevated transaminase. And for monospot test, we use to detect heterophile antibodies, which are highest during the first 4 weeks of disease. And if the test is positive in a patient with classical symptoms and sign of infectious mononucleosis, this will strongly support the diagnosis of the disease. And we do other serological tests to detect EBV-specific antibodies if the heterophile test is negative. And we can look for viral capsid antigen, IgM, and IgG, and also anti-Epstein-Barr nuclear antigen antibodies in the serum. Okay, for complication, patient can have splenic rupture, can either be spontaneous or due to mild trauma, and also airway obstruction due to tonsillar swelling. And neurological conditions such as headache is common, but others such as symptomatic meningitis or encephalitis, seizure, and ataxia are rare, and also hematological abnormalities such as thrombocytopenia and leukocytosis. Okay, for management, there is no specific treatment. The mainstays are rest, adequate fluid, and also adequate nutrition intake. And we should advise the patient to avoid excessive physical activities because if there's splenomegaly, it is prone to rupture. And we can give symptomatic treatment, including NSAIDs and acetaminophen for symptoms such as fever and sore throat. And also short course of corticosteroids may be helpful in patients with complications such as obstructed airway. And for prognosis, the majority of the patient recover without sequelae and will develop lifelong immunity to control the dormant virus. Okay, the next one is Rosella infantum, or it is also called as exanthum subitum. So exanthum means eruption or rash on the skin, and exanthum subitum simply means sudden rash, which is the clinical feature of this disease. Okay, so for Rosella infantum, it is a clinical syndrome characterized by 3 to 5 days of high fever, which may exceed 40 degrees Celsius, and then the fever will resolve abruptly and is followed by development of rash, which is non-pruritic, pink papular rash that begins on the trunk and will spread to the other part of the body. And the etiology is due to infection by human herpes virus 6 and less commonly human herpes virus 7. And it is also known as exanthum subitum and 6 disease, and it is an acute self-limited disease of infancy and childhood. So in this table, these are the common infectious exanthums in childhood from the 1st to 6th disease, which you can take a look later. Okay, for the epidemiology, it occurs in young children with a peak prevalence between 6 to 9 months, and 90% of the cases occur in children below the age of 2 years. And it occurs equally in boys and girls. And the transmission is through contact with the saliva or respiratory droplet of asymptomatic adult or older children. But congenital infection is also possible through transplacental infection, and the virus can also integrate in the chromosomal region of. I'm sorry, what? Congenital infection is possible, but it is rare, like only 1%, and through transplantal infection and chromosomal integration of the virus at the telomere. Okay, for pathogenesis, the infection begins after patients come in contact with the respiratory or salivary secretion from adults or older children who shed the virus. And this virus has tropism for T cells, CD4 T cells, and they will replicate in the cells and also in the salivary gland. And HHV6, they can infect a broad range of cell types, including primary T cells, monocyte, NK cells, and also astrocytes due to because one of its cellular receptor is CD46, and CD46 are presented on surface of all nucleated cells. And primary infection with these two viruses, they can also induce lifelong latency and persistence at multiple sites, but particularly in monocytes and macrophages.
Semula tadi. Pergi balik semula. Okay.
Which one?
Yang depan sikit. Forward. To belakang, backward, forward. Okay ha. Okay ha.
Okay, so for clinical features, okay, the clinical course, the incubation period is usually for 1 to 2 weeks, and the clinical course of this disease is characteristic. After incubation period, the child will develop 3 to 5 days high fever and plus several other symptoms during the febrile phase, such as acute otitis media and periorbital edema. And after the fever resolves, there will be development of maculopapular rash, which is non-pruritic. For history,
Belakang semula. Postural ocular lymphadenopathy. Apa doga yang mas spot tu apa?
I will explain during examination in the next slide. Okay. So for history of presenting illness, so since this disease usually occurs in an infant aged 9 to 12 months in previously good health, but the child is presented with high onset of fever. And the duration usually lasts for about 3 days, and it is accompanied with irritability, such as persistent crying, and there can also be history or complaint of febrile seizure in 50% of the patient. And patient can also notice appearance of rash after the fever has subsided, and the rash is usually faint pink or rose-colored, non-pruritic, evanescent, which means it only lasts for a few hours and then disappear, but it can appear again. And starts from the trunk and spread to the face and extremities. And the rash usually lasts for about 1 to 3 days. There can also be presentation of other associated symptoms such as rhinorrhea, vomiting, and diarrhea. And lower respiratory tract infection symptoms are less frequently identified, unlike in other viral diseases such as measles. Other important history include past medical and surgical history if there's any immunodeficiency, and also developmental history because certain congenital infection can lead to developmental delay, and also immunization history to look for risk of infection by measles and rubella because these are some of the differential diagnoses for this disease, and also drug history. Antibiotic allergy can be confused with the development of Rosella rash, and also social history if the child lives in a crowded environment, such as daycare center. Okay, during physical examination, we can see blanching, macular or maculopapular rash, which is usually non-pruritic, and it is faint pink or rose-colored, such as in the picture. And they can also be cervical, post-auricular, or post-occipital lymphadenopathy. And they can also be palpebral conjunctivitis, edematous eyelids, and also acute otitis media. And patient can also be presented with uvulo-palatoglossal junctional macules or ulcers. And sometimes it is called as Nagayama spots. And this Nagayama spots is usually characteristic for Roseola infantum. And the chart can also be presented with a bulging fontanelle. Okay, so for differential diagnosis, primary infection with either HHV6 or HHV7, they usually cause an undifferentiated febrile illness that may be difficult to distinguish from other common infections of childhood, which can be grouped as infectious exanthems. So basically, these are the common infection in childhood that can lead to appearance of rash. Because childhood rashes may be difficult to differentiate by the appearance alone, it is important to consider the entire clinical presentation to help make the appropriate diagnosis. So we must consider the appearance and the location of the rash. For example, in Roseola infantum, the rash usually starts at the trunk and spread to extremities. And for erythema infectiosum, which is an infection by parvovirus, the rash is usually prominent on the cheeks. And for the clinical course, we also need to consider the clinical course because characteristic of Roseola infantum is that the rash appears after the fever. But in some diseases such as rubella, there can be simultaneous presentation of fever and also rash at the same time. Also, we need to consider associated symptoms such as pruritus or fever or pharyngitis, which is more common in scarlet fever. And also the age group. The Roseola infantum is common in infant aged 9 to 12 months, but disease such as scarlet fever is not common in children below 3 years old. And we can also look for common signs in certain diseases such as Forchheimer spots, like in the picture, which can be presented in rubella, measles, and scarlet fever, and also characteristic of measles, which is Koplik spot. And for Nagayama spot, it is usually characteristic of Roseola infantum. The other differentials include drug allergy, and it is an important consideration in children with fever who are treated with antibiotics and then develop a rash. But in allergy, the rash is usually pruritic, while in Roseola infantum, the rash is non-pruritic. And if the children is presented with pyuria, we need to consider urinary tract infection. Thus, we need to rule out UTI. Okay, so these are the table of differential diagnosis for the infectious exanthems that I have mentioned before, and there are specific clinical presentation which you can go through later, and this one also. So for diagnosis and investigation, this Roseola infantum is a clinical diagnosis whereby the patient usually presented with history of 3 days of high fever in a 9 to 12 months old infant by abrupt defervescence or loss of fever, and then they will develop a blanching maculopapular rash on the trunk which can spread to extremities. So we can do full blood count, and usually there will be neutropenia, lymphocytopenia, and thrombocytopenia. And then we can do urine, FEME, and also culture and sensitivity to rule out urinary tract infection if there is any presentation of fever and sterile pyuria. And we can do viral culture, which is the gold standard, but it is not commonly done because it is expensive and it is not readily available. We can do PCR to detect viral DNA and serological tests to detect antibodies to HHV6 and HHV7. But in general, we usually don't do laboratory evaluation except in manifestation of if the manifestation of the disease is severe and if the patient can benefit from antiviral therapy. Next, the complication. The first one is seizures. But it is usually rare and it does not occur, it only occurs once, and the patient is not expected to have further febrile or non-febrile seizures. Patient can also have aseptic meningitis, encephalitis, thrombocytopenic purpura, and reactivation in immunocompromised hosts. And for management, there is no specific therapy, but mainly we focus on supportive care, such as ensuring adequate fluid intake for infants with diarrhea and vomiting, and symptomatic signs such as fever, we can give antibiotics. And antiviral is usually not indicated unless in unusual or severe manifestation of the disease, such as encephalitis in immunocompromised patient, and we can give ganciclovir, foscarnet, and cidofovir. And for prognosis, majority of the children with primary infection will recover uneventfully without sequelae. That is all from me.
Okay, good. Next presenter. Next presenter. Apa benda tu? Tak nampak apa pun. Slide apa ni?
Sorry. Tak nampak Dato.
Slide ni je.
Sorry Dato. Can you guys see my slide?
Besar ni slide yo.
Can we? Sorry Dato.
Mesti pakai handphone, betul tak?
Because my laptop. Doktor, laptop saya rosak.
Dia pakai handphone ke? Laptop rosak, tapi slide tak nampak.
Kalau
try rotate your handphone to landscape mode.
Better. Okay,
Okay. Okay, Bismillahirrahmanirrahim. I'm Nohafira binti Muhammad. We'll be presenting on the topic of measles, mumps, and rubella. And this is the contents for my topic today, from the introduction until the prevention, which I will include the MMR vaccine also. Next. So we will start with the measles first. Measles is also known as rubella. It is a highly contagious disease, but since the introduction of an effective MMR vaccine, the incidence of measles has reduced dramatically. In underdeveloped countries, the measles is most common in children under under 2 years old, but it can affect in all ages, and male and females are equally affected. Measles disease are characterized clinically by a typical prodrome such as fever, cough, coryza, conjunctivitis, complique spots, and followed by a general maculopapular rash. The cause of this measles are due by a measles morbillivirus, the family of Paramyxoviridae. It's a single-stranded RNA virus. This measles virus has two important structures that involve in pathogenesis, which include there are two membrane envelope glycoproteins such as which is fusion that mediates in viral penetration, and the other one is hemagglutinin, function as receptor attachment. This virus only has one antigenic type, and it confers lifelong immunity if previously infected. And human is the only natural host, and the mode of transmission of this virus is through droplets or the airborne route. For example, when coughing and sneezing. And moving on to the pathogenesis, unlike the other two viruses, this measles virus will remain active and contagious for up to 2 hours in the air. And when it enters through our respiratory tract, it will multiply locally in upper respiratory tract and will spread to the regional lymph nodes and reticuloendothelial cells, and the primary viremia will occur, particularly during the 2nd to 3rd day of infection, which are in the period of incubation period. And after that, it will spread to the respiratory tract, body surfaces, and other organs, where this is when the secondary viremia occur, usually in the 5th to 7th days of infection. And after the secondary viremia occur, patient will experience prodromal illness, where in this phase, the virus will start to shed and people will start to be contagious. And after the secondary viremia also, the onset, there is appearance of rash, which with the antibody production and viral replication, and the symptoms will begin to subside during the onset of rash. In general, this disease, this infection causes generalized immunosuppression in patients, and because it primarily affects the macrophages, dendritic cells, and lymphocyte. And this is why people with immunodeficient can get into more severe condition. Next, the clinical manifestation of measles virus. The period of infectivity or communicability is around 1 to 2 days before the onset of the symptoms to 4 days after the onset of the rash. And this measles virus involves 4 phases. The first one is incubation period that lasts around which range from 8 to 14 days. And after an incubation period, prodromal or catarrhal period will start with mild fever, the classic triad of conjunctivitis, cough, and coryza, or we can simply remember as 3 Cs. And at the late stage of this phase, the fatal pneumonic complete spots will appear. It usually appears 1 to 2 days before the appearance of rash and can last until 2 days after the rash appears. Fatal pneumonic is defined as sign and symptom that is specifically indicative of a particular disease. So in this case, complete spot is especially indicative for measles virus. And next, after the prodromal period, it is followed by exanthematous or rash period, where the rash will start to appear, which is around 1 to 4 days after the onset of complete spots, and start to disappear after 4 days. And during this time, patient will start to have a high-grade fever, often for over than 40 degrees Celsius. And the last phase is a recovery phase, where patient will have the persistent cough that is often up to 10 days. Next, these are the clinical manifestation that I've just mentioned just now. It is first appear as discrete lesions with bluish white spot with the size of and it usually appear in the center of inner aspects of cheeks at level of the premolars, and it may spread to involve lips, hard palate, gingival folds, and vaginal mucosa. And next is Stimson line. Stimson line is a characteristic of conjunctivitis in measles. It is characterized as transverse line of inflammation along the eyelid margin. Next is maculopapular rash. It is characterized as red blotchy patch that can be both flat and raised. It usually begins on the forehead, which is around the hairline and behind the ear and upper neck. It can spread over the most of the body in a capillate to caudal pattern over the period of 24 hours. It is confluent on face and upper trunk. And as rash start to fade, it undergoes brownish discoloration and disformation. And other clinical findings would include cervical lymphadenitis, splenomegaly, and mesenteric lymphadenopathy with abdominal pain, but this mostly occurs in severe cases. Next, and on how we approach people with measles virus. During the history taking, we ask in history of presenting illness, we ask the details of the presenting complaint. Usually patient will present with fever, cough, rhinorrhea, and conjunctivitis And then we ask about the onset of the symptoms, the duration. If possible, we ask the date of the start of the symptom in chronological order. And then we ask about the associated symptoms such as headache, irritability, skin itchiness, and rashes. And in past medical history, we ask if the patient has been diagnosed with HIV or AIDS, or history of immune deficiency disorder, and have taken corticosteroid therapy, or patient in malnutrition have been diagnosed with malnutrition. And the next one is family history. We ask if the patient have been exposed with family members with the same illness, and because it may infect the patient. And then social history, if patient been in crowded environments such as in the daycare center. And then immunization history, this is the most important part, and also travel history, if the patient has traveled to the endemic area. Next, in physical examination, in general, patient will look ill and febrile, and the vital signs usually in vital signs, patient usually presented with mild to high-grade fever. And then in face examination, we look for facial rash, and in eye, we look for symptom line to assess for conjunctivitis. And then during examination, we can look for Koplik spot, but this Koplik spot, it may not be present in all the case, even though it is pathognomonic. And the absence of these signs cannot exclude the diagnosis. And then we look for maculopapular rash. Maculopapular rash this rash is characterized as blanching rash, where when we press the rash, it will start to disappear. And then lymphadenopathy. We look for any palpable lymphadenopathy, such as at the cervical area and mesenteric lymph node. Lastly, in abdomen, we inspect if there is distension and palpation to look for tenderness and splenomegaly in severe cases. Next is diagnosis and investigation. For measles virus, this diagnosis is almost always based on clinical findings, and the routine lab findings are non-specific and do not aid in the diagnosis. But definitive diagnosis can be determined by serologic testing for IgM antibodies, which will appear within 1 to 2 days of fresh and persist for 1 to 2 months. And other lab findings such as full blood count, the findings are leukopenia, the decreased number of white blood cells, and ESR and CRP may be elevated if it is complicated with bacterial infection. In management, patient should be isolated and require hospitalization, and management is usually symptomatic. For example, we give antipyretic to relieve the fever, and there is no antiviral therapy specific for measles virus. And we also need to maintain, patient need to maintain fluid intake and nutritional state. And in immunocompromised patient should be given antivirals such as ribavirin, and patient also need to be supplemented with vitamin A therapy, and is given with antibiotic in patient with secondary bacterial infections such as otitis media.
Tak perlu masuk ward semua. The patient can take orally well, right? Usually kita admit patient yang unable to take orally well dia. Patient can take orally well, kita kasih PCN, go back home dia. Buat apa kat masuk ward? Kita tidak penuh ward dengan budak measles. Or patient is immune deficiency. Next, apa lagi slide?
Usually complication of the measles virus is caused by suppression of host immune response that leading to the super infection by bacterial infection. And it is likely to occur in children less than 5 years old or more in adult in more than 20 years old. And the risk factor will include children with immunodeficiency disorder, malnutrition, vitamin A deficiency, inadequate vaccination, and immunocompromised patient. And the most common, the common complication is pneumonia, diarrhea, croup, malnutrition, otitis media, mouth ulcers, and also eye complications. Next, the second disease is mumps. Mumps is a highly contagious disease, and since same as the measles just now, since the introduction of the MMR vaccine, the incidence has declined dramatically, except in non-immunized child and unvaccinated young adults. It is predominantly affects school-aged children, range around age 5 to 14 years old, and male and females are equally affected. It is characterized clinically by fever, bilateral or unilateral parotid swellings, and tenderness. This mumps virus is caused by rubella virus.
Balik semula.
Sorry, Dato?
Ya, ke belakang tu, backward. Okay. Okay, forward.
This mumps virus is caused by rubella virus, the family of Paramyxoviridae. It is a single-stranded RNA virus. There are two structures that are involved in the pathogenesis of mumps virus. The first one is F protein or fusion protein that mediates in penetration of virus into the cells, and also HM protein or hemagglutinin neuroaminidase protein that mediates absorption of the virus to the host cells. It has only one immunotype, and human is the only natural host. The mode of transmission of this virus is through droplets or the airborne route, especially when coughing and sneezing, same as the measles virus. And the pathogenesis of this measles virus is almost similar as mumps virus. And this mumps virus is almost similar as measles virus, where when the virus get entry into our respiratory system, it will multiply locally in upper respiratory tract and regional lymph nodes, where this is when the primary viremia occur. And then it will start to spread to spleen and distant lymph nodes, and secondary viremia occur. And lastly, this virus will start to replicate and spread to the generalized spread to salivary glands and other organs such as CNS, testes, ovary, kidney, and others. And for clinical manifestation of mumps virus, the incubation period is 16 to 18 days, and the period of contagious or period of infectivity is around 7 days, which is 1 to 2 days before to 5 days after the onset of parotid swelling. The prodromal illness lasted around 1 to 2 days with fever that usually resolves in 3 to 5 days, and headache, vomiting, and achiness. Then parotitis will start to appear and may be unilateral, but becomes bilateral in 70% of the cases. It is characterized as tender, red, and warm, and it usually preceded or accompanied by ear pain on its lateral side. And other clinical findings would include trismus or lockjaw, which patient is unable to open the mouth or jaw and can cause pain on eating and drinking, anorexia and loss of appetite due to the trismus, and morbilliform rash. This morbilliform rash is rarely seen. And then apart from parotid swelling, submandibular swelling also can involve in mumps virus with or without the parotid swelling. And it is complicated, and the other clinical findings of is meningeal sign, edema over the sternum or genitalia area. And how we approach patient with mumps virus during the history taking. Patient usually presented with facial and neck swelling, and then we ask about the site of swelling and whether it is pre-sternal or genital area, and the onset and duration of the swelling, the characteristic of the swelling, is it erythematous, warm, pain? If it's pain, then we ask the other side of the pain, usually in salivary glands, ear, and genitalia. And this pain may be aggravated by a chewing movement of the jaw. And then ask about the associated symptoms such as fever, vomiting, headache, achiness, loss of weight, trismus, rashes, and neck stiffness. In past, and the other history is almost similar as measles virus. Moving on to the physical examination, during general examination, we can see patient is in pain with facial swelling, and patient also may presented with patient also may be dehydrated due to pain in swallowing of fluid, and fever is usually mild. And on face examination, we check for any palpable salivary gland. In most of the cases, parietic gland will be swelling and palpable. And as I mentioned just now, submandibular glands also can be may be involved with or without the parietic swelling. And this swelling is characterized as edematous, red, warm, tender. And then we look for any facial rashes. During the mouth examination, we assess for trismus. Trismus is defined as a mouth opening less than 40 millimeter, or when we examine, we cannot fit 3 fingers lined vertically between the top and bottom tip in front of the mouth, as in the right picture. And then also we can look for erythematous and putting Stensen's duct and Wharton's duct. This duct is function as to drain the saliva. Stensen's duct, also known as parietic duct, we can see the pathological Stensen's duct near the second upper molar, while for Wharton's duct, we can see under the tongue, as in the picture below. And then neck and chest examination to look for any pre-sternal edema. And then we look for morbilliform rash that characterized as rose red flag or slightly elevated erection, but this rash is usually rarely seen. And other examination, severity or complicated, condition. For example, in abdomen examination, we do palpation to examine pancreatitis. The patient will experience epigastric pain and tenderness. And then genitalia examination to look for testicular tenderness and swelling in patient with orchitis. In female, we do pelvic examination to look for pelvic tenderness in oophorytis. And then we can do neurological examination to assess for meningeal signs. For example, we can do the knuckle rigidity test, where patient will enable to flex the neck forward. This is happen due to the neck stiffness of the meningeal signs. Next, for the diagnosis and investigation, in mumps virus, this diagnosis is almost always based on clinical findings, but definitive diagnosis can be made from viral isolation in cell culture and serology of viral antigen, which we can isolate it from urine, saliva, throat swab, or CSF. And other than that, we can measure serum IgG antibodies, which will be elevated. Other lab findings would include leukopenia, lymphocytosis, and serum amylase will be elevated, that suggestive of parotitis. And CSF in meningitis, usually the result will be normal or low glucose, and normal to mildly elevated protein in patient with CNS complication. And then management is usually symptomatic, where we can give analgesic to relieve the pain and antipyretic to relieve fever. And There is no antiviral therapy specifically for mumps virus, and adequate nutrition and mouth hygiene is important, and bed rest guided. The complication of mumps virus, for mumps virus, the most common complication will involve neurological and reproductive system. For neurological, the most common one is meningoencephalitis. It is most frequent complication, and it may occur before, along with, or following perioditis. And the typical clinical findings would include neck stiffness and seizure. And patient also may have transient hearing loss. And for reproductive, orchitis with or without epididymitis can occur, but this is rare in pre-pubertal boys, and phthiritis is uncommon in pubertal females. Other than these two symptoms, CVS, GIT can also, the complication in CVS and GIT can also occur, such as myocarditis, hepatitis, pancreatitis, but this is rare in childhood, and also arthritis, thyroiditis, and mastitis. The last disease, the last virus is rubella virus. Rubella virus is also known as German measles and 3-days measles. It is moderately contagious disease, and it is mild, often asymptomatic disease of infants and children. But nowadays, it is more common in young adults, more than 20 years, and typically more severe. And males and females are equally affected. And the major clinical significance of this rubella virus is due to the transplant-centered infection and fetal damage in congenital rubella syndrome that we'll explain later. Rubella virus is caused by rubivirus, the family of Togaviridae. It is a single-stranded RNA virus. It only has single serotype that can confer lifelong immunity if has previously infected. And human is the only natural host. The mode of transmission of this virus is through the respiratory droplets or the airborne route, and also transplant-centerly. The pathogenesis is almost similar as to previous virus, where it gains entry into our into the respiratory system, and then we start to locally multiply in the respiratory tract and regional lymph node, and then we further spread to the spleen and distant lymph nodes. The incubation periods of rubella virus is around 14 to 21 days, and the period of contagious or period of infectivity is 14 days or 2 weeks, which is 1 week before and after rash. And then the prodromal illness of rubella virus would include low-grade fever or no fever at all, sore throat, red eyes with or without eye pain, headache, malaise, anorexia, and lymphadenopathy that usually prominent in suboccipital, post-auricular, and anterior cervical lymph node. And it can usually in rubella virus, the rash only presented 3 days, which during only presented 3 days. That is why it is called. That is why it is also called as 3-days measles. In day 1, the rash usually starts from face with small irregular pink macules and rapidly spread to whole body that will be characterized as discrete macules. And during the day 2, this rash will begins to fade on the face, and the last day, day 3, will start to disappear throughout the body. And this rubella virus is subclinical infection, and most of the cases, 25 to 14% of the cases of children, maculopapular rash may not be presented. And other clinical findings is formic spots, which is the particle lesions on the soft palate, and also splenomegaly in severe case. And how do we approach patient with rubella during the history taking? Usually patient will presented with rash and neck swelling, and then we ask for the site of the rash and the swelling. For the rash, is it involve face or the whole body? And for the swelling, the location of the swelling and the onset of the duration of the symptoms and the characteristic of the rash. Is it accompanied by itchiness, diffuse or localized, and swelling? Is it accompanied by pain? And then associated symptoms. We ask for the associated symptoms that would include fever, sore throat, conjunctivitis, headache, malaise, and anorexia. And I'm sorry for the error there. And for other history, is almost similar as the two previous virus. And during physical examination, during general examination, usually patient will appear well, and in vital cell examination, usually patient will have low grade fever or no fever at all, and we check for facial rashes. And during oral examination, we look for me. It is suggestive of rubella virus, but not diagnostic. And we can assess for maculopapular rash, which is blanch rash. And then we look for lymphadenopathy. We assess for shape, tenderness, and mobility. And then abdomen to assess for any organomegaly in severe cases such as splenomegaly. Next, this the diagnosis and investigation. Unlike the other two viruses, the clinical diagnosis of rubella may be difficult to make because it is subclinical, and most of the patient may appear asymptomatic. And other than that, it is because many asymptomatic disease may mimic rubella infection. And to confirm this rubella virus, we need to do laboratory studies such as serologic testing, where there is elevated in antibody titer with 4-fold rise in rubella specific IgG. And other laboratory findings would include leukopenia, neutropenia, and mild thrombocytopenia. And definitive diagnosis also can be made from viral isolation in cell culture and serology of viral antigen. For the management, there's no specific therapy for rubella. It will be managed as a symptomatic treatment that will include maintaining adequate hydration and give antipyretics. Next, the complication. And other than congenital rubella syndrome that arise from rubella infection during pregnancy, the complications are rare, where, for example, encephalitis, myocarditis, arthritis, and also hematological disorders such as thrombocytopenic purpura and hemorrhagic manifestation. Briefly about the congenital rubella syndrome, this CRS is defined as an illness in infants that results from maternal infection with rubella virus during pregnancy. It usually occurs when non-immune pregnant woman is infected during the first trimester, usually first month. This is where the gestational process happens, and serious consequences such as miscarriage, stillbirth, and a constellation of severe birth defects in infant can occur. And this fatal infection occurs transplacentally during the maternal viremic phase. This CRS may present classic triad of cataract, cardiac abnormalities, and deafness. Other manifestation, as in the picture, is microcephaly, mental retardation, hearing loss, hepatos, splenomegaly. And we can investigate by doing assess IgM in fetal blood and also virus isolation or PCR in amniotic fluid. Lastly, prevention, which I will explain regarding the MMR vaccine. Basically, MMR vaccine is 3-in-1 vaccine.
Tak payah. Ni. Dah pukul 12 suku dah. Awak nak pergi sembahyang Jumaat ni.
Okay, that's all. And this is my reference. Thank you.
Berapa orang lagi presenter?
2.
Come. Cepat. Siapa lagi? Alisa. Okay, Uvila Zoster. Okay, start.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So, my name is Sarudin. Today I'll be presenting about zoster virus. So, this is the outline of my presentation. So, we start with introduction. Zoster virus is actually one of the human herpes virus. In fact, it is a human herpes virus type 3 out of 8. It is an ambular eicosahedral capsid and it has double-stranded DNA. The subfamily is alpha herpes virinae together with HSV1 and HSV2. It has a very short reproductive cycle and primary target cell is usually mucoepithelial.
Pelan-pelan, relax lah. Laju sangat apa?
The latency site is at the neuron and usually the natural host is human. It is very contagious, especially during the virus shedding time. Usually 2 days before the onset of rash and 7 days after the onset of rash. And then the mode of transmission is via respiratory droplets, direct contact with lesion, and also intrauterine infection. However, it is quite rare. It actually infects all age, but the peak incidence is among pediatric population, and then it has lifelong immunity. So once the patient has been infected with chickenpox, it is less likely for them to get second chickenpox. However, it can occur. And then the incubation period is around 10 to 23 days. It has high mortality in immunocompromised patients. For example, patient with leukemia, any transplantation event, prolonged corticosteroid therapy. Usually it is a self-limited disease, so we treat them symptomatically because it will resolve spontaneously. Okay, so for epidemiology, it is a very common disease among pediatric population. However, in pre-vaccine era, the peak incidence is around 5 to 10 years old. But after the post-vaccine era, it is the peak incidence is much later, which is around 10 to 14 years old. The peak season is around late winter and spring because during this time people tend to sneeze and cough, and this will transmit the disease easily. And then after the post-vaccine era, the incidence has been decreased, and also the mortality rate decreased significantly. Usually countries with tropical and semi-tropical climate have a higher incidence of adult chickenpox compared to temperate climate. For pathophysiology, firstly, the virus will infect the upper respiratory tract, and then 2 to 4 days later, it will replicate in regional lymph node. So after 4 to 6 days, the primary viremia will infect the reticuloendothelial system such as lung, liver, spleen, and then all the blood that come out from RES is now known as secondary viremia. And during this time, this viremia will disseminate to other visceral and skin, and this will infect keratinocyte, which is the cell-to-cell direct infection. And this infected cell can diffuse together, forming the T-zyme cells. And then it can also infect the sensory neuron by traveling retrogradely from the skin to the dorsal root ganglion and remain latent there. But most of the time, this virus will be eliminated by our immune cells, but it can be reactivated again if the patient has immunocompromised state, and it results in shingles by traveling retrogradely to the skin. And then for booster taking, usually in pediatric population, they will come to you. Sorry?
Like what? Okay, huh?
For booster taking, usually pediatric population, they will come to you with rash manifestation as the first symptoms, rather than adult, they may have prodrome symptoms. So when the patient comes to you with rash characteristic, we have to identify some of the characteristics to rule out some differential diagnosis and to confirm the chickenpox disease. So firstly, the texture, we have to know, is it a smooth, rough, or scaly? As for the chickenpox, usually it is associated with bump, which is coarse, and it has fluid cavity inside. And then we have to ask the patient where the site first began, because some disease, the rash will start from periphery and then it spread to the trunk. However, in chickenpox, it usually concentrated on trunk and head first, and then it's spread peripherally. And then we have to ask the patient the distribution of the rash. Is it localized, generalized? As for shingles, it may be localized and unilateral, but for chickenpox, it is usually generalized. And then the color of the rash. Usually, chickenpox it will associated with a red rash because it has erythematous base. But if it associated with white patches, then we can include eczema. If it has purple light colored, we can suggest meningococcal infection. And then if it is silver light colored, it means psoriasis. And then we have to look for the rash. Is it uniform, patchy, or blanching? But for chickenpox itself, it does not blanch. But in shingles, it can be patchy. And then we have to identify the exacerbating factors of the rash. Is it exacerbated by warm shower, physical activity, or sun exposure like SLE rash? And then any other additional characteristic of the rash, is it associated with itchiness, sore, tingling, and scabbing? As for chickenpox, usually it is associated with itchiness and scabbing, but for shingles, it is associated with tingling sensation and scabbing. And then we have to ask any accompanying symptoms after the onset of rash, because some disease, after the onset of rash, the fever will subside and the patient may feel better. But for chickenpox, patient will have prolonged symptoms of fever, and then after the onset of rash, it will continue for about 3 to 4 days later, and then only it subsides because the new lesion has ceased. And then for a systemic review of for history taking, we have to look for every system because we want to
tengok semua benda ke? Palpitation, chest pain, semua. You are not like that. You just give us the positive, negative signs, positive sign je lah. Nak go through semua ni.
No.
Chickenpox present apa? Dengan edema, fatigue.
No. This is if the patient comes to you with complaint of other additional complaint like palpitation, jasmine, that we can suspect.
Payah. Forward.
Okay. For past medical history, we have to ask the patient been infected with chickenpox before, because it will support the next.
Forward. Itu saja. Clinical feature dulu.
Okay.
Ya.
For clinical features, usually in adult they will have prolonged symptoms for about 1 to 3 days. Usually it will associate with non-specific symptoms such as low-grade fever, malaise, anorexia, headache. However, in children, the first symptom will be skin rashes or eruption. So it usually appears in crops for about 3 to 5 days, and usually start from trunk and head, and then it spread peripherally, but in a lesser extent. And then it is associated with marked pruritic rash, and the patient may complain to you that the fever will subside after 3 to 4 days after the onset of rash. And then for vesicular lesion, okay, we can identify that the rash is vesicular in nature. It has fluid blisters that the fluid will range from clear to cloudy. It has erythematous base, and this rash, it has progression. It first appears as small macules, and then it forms red papules, then non-umbilical vesicle, pustules, and scab. It has rapid progression in hours. So once the patient comes to us with this characteristic, we can identify multiple stages of the rash. Some lesions are healing and some lesions are still newly developed. And then it will usually fall off within 1 to 3 weeks. It is associated with no or minimal scarring compared to shingles, and they will have generalized lymphadenopathy. And then these are the stages of eruption and the definition of each stages. You guys can read it on later. And then for complication, usually patient will can get a secondary bacterial infection because of the marked pruritic rash. They will tend to scratch their skin, causing broken skin, then facilitate the entry of the microorganism. Usually it can be caused by streptococcus and staphylococcus. And the marked secondary bacterial infection usually impetigo. But if patient present with life-threatening secondary bacterial infection, it can be toxic shock syndrome and necrotizing fasciitis. And then it can also complain of a present with purpura fulminans and hemorrhagic lesion. And for the head, they may get corneal lesion and stroke. For central nervous system, they may get cerebralitis, aseptic meningitis, and generalized encephalitis. But general encephalitis usually associated with cerebralitis. It has good prognosis and it occurs early during the illness. Usually, the most common presentation of this encephalitis, patient will come with acute truncal cerebellar ataxia. And for cardiovascular system, they may get myocarditis and respiratory pneumonia. However, it is uncommon in healthy children who got infected with chickenpox. And smokers have higher risk. And then for GIT, patient may have acute glomerulonephritis and hepatitis. For musculoskeletal,
You nak kita belajar jadi You nak jadi pakar ke?
Sorry?
You nak jadi pakar? You bukan jadi pakar. Tadi you call it, want to discuss everything about complication. Complication can be anything under the sky. You nak jadi doktor biasa je. Apa ya cerita semua benda ni yang jadi apa tu? Just mention saja Raynaud syndrome ni semua Ini akibatnya kalau you sure download somewhere is it? You type sendiri. Tapi kenapa you complicated sangat? You baca semualah Raynaud syndrome semua. Letih lah. Patutlah medicine tu menakutkan. Forward tak apa. Macam tadi, simple je tadi. Macam diorang you call it present, semua simple je. That's your level. Tak payah nak go very deep in term of complication. You go even itu mum's complication tu banyak tau. Encephalitis ini semua tu dipanggil apa tu pyruvate encephalitis semua tu tak payah tahu benda macam tu. It's not your level. Okay, ini
For investigation, usually we diagnose chickenpox via clinical diagnosis and we rarely need lab test confirmation. But if we suspect complication, then we can take for food bakar, look for hemoglobin level, a platelet, to look for the IC, and then the white blood cell count. If it has neutrophilia, then it can suggest secondary bacterial infection, and then high lymphocyte suggests viral infection. And then for liver function test, increased ALT can suggest hepatitis complication. And then we can also do lesion culture to look for the secondary bacterial infection to give proper antibiotics. And then T-zyme smear to confirm that this is a herpes lesion. And then for definite diagnosis, we can do PCR, genotyping, immunofluorescence, and serology. However, we rarely do. And then we can do chest X-ray if we suspect pneumonia and lumbar puncture.
Lumbar puncture pun tak payah. If you say to me you're going to do lumbar puncture in chickenpox, you're going to fail. Faham tak? Because that's not the investigation. If you told me you want to do lumbar puncture because the child got encephalitis, the diagnosis will be encephalitis secondary to chickenpox. It's not the diagnosis chickenpox anymore. Faham? So don't need to mention about all this. Kita colleague tadi mana mention all these things. Proceed. You confuse you all tau.
For differential diagnosis of particular rash, it can be eczema herpetica or kaposi varicella eruption, which is a serious complication of atopic dermatitis. It manifests as eruption of multiple pruritic vasculopustulation. However, it different from chickenpox because usually chickenpox will manifest as non-umbilical teardrop vesicles, but for this lesion, they will have cluster umbilical papules, and it also caused by herpes simplex virus. Usually, it develops over the body, but more concentrated on skin that has skin problems such as eczema. But for chickenpox, it will be a generalized rash, and then it appears on the dermatoma distribution. And then the settlement and shingles that I will be discussing later. And then the hand, foot, and mouth disease that commonly caused by Coxsackie virus sepsis, they also have prodrome symptoms. However, the lesion usually localized to extremities and oropharynx compared to chickenpox. And then it's also erythematous based. It has blanching rash with fine petechiae but not itchy but painful. So the patient can come to you with sign of dehydration because of the painful upon swallowing. And then for herpangina, it also caused by Coxsackie virus. It has vascular eruption, but on face, soft palate, and uvula. It is not very generalized. A small tender, popular or pinpoint vascular lesion that differentiate it from chickenpox virus. It can also lead to anorexia because of painful upon swallowing. For management,
belakang, backward. Okay,
For management, usually military have mild case and we just treat them symptomatically because it is self-limited and they will resolve spontaneously. So we give non-aspirate antibiotic, cool bath to ease the itchiness and maintain good hygiene. And then antiviral we can give in immunocompromised patient via intravenous acyclovir. after 24 hours onset of rash to reduce the complication. And then adult, we can give oral paclitaxel or varicella, and children, we give acyclovir. For varicella zoster immunoglobulin, we can give to immunocompromised children, and also to the baby that the maternal chickenpox developed shortly before and after the time of delivery. And then antibiotic we give if we suspect secondary bacterial infection. For prevention, usually children, we not allow them to go to school until all the basket are trusted. And if they have been hospitalized, we have to isolate them into negative pressure room to prevent the transmission. And we may promote live attenuated varicella vaccine. In children, we give 2 doses that are spread more than 4 weeks apart. Usually, we give within 12 to 15 months and 4 to 6 years. And then varicella zoster immunoglobulin, we give to patients that have increased risk to get severe illness. And then for shingles, it is the same virus as chickenpox. In fact, it is a reactivation of the latent varicella zoster virus within the dorsal root ganglion or cranial nerve ganglion. So it has caused vesicle eruption in the dermatomal distribution. Usually, it affects the thoracic and also lumbar area, and it is uncommon in children. But if it happened to be in children, maybe the patient may have primary varicella infection in the first year of life. In immunocompromised person, they tend to get recurrent or multi-dermatomal shingles. And the mode of transmission is via direct contact with vesicular fluid, and it is also a self-limited vesicular rash, but associated with acute neuritis. For epidemiology, it affect only 5% affect.
Backward. Okay, continue.
Only 5% of cases affecting patients less than 50 years old, and an increased incidence with age, but peaks around 70 years old, and incidence increase in immunocompromised person in order to activate the virus. And then the phase of illness and its clinical features, usually it has 3 phases. The first one is pre-eruptive phase, in which there is no yet rash, but the patient complains to you with pain and numbing, tingling sensation of the skin. It may occur in one or more dermatome, and usually it occurs in the area where the rash will develop later. And patient may complain with headache, nausea, malaise, fatigue, upset stomach, and uncommonly fever. Usually it lasts for about 1 to 10 days. And then for acute eruptive phase, it is associated with severe pain of the herpeticum vesicle. It has erythematous patchy-based rash. It affects one or more dermatome, but usually unilateral. It occurs in the distribution of sensory nerve, and usually the lesion does not cross the midline. The patient will have regional limb adenopathy. For about 1 to 2 days, the rash will consist of clear vesicle that will turn cloudy, and then it ruptures and cross over in about 7 to 10 days. It's more common in thoracic and lumbar area, and usually acute eruptive phase lasts for 2 to 3 days. And then chronic phase. It can occur for years even after the shingle has resolved. It associated with complication, and the most common complication is post-herpetic neuralgia. The patient will complain to you with persistent and recurring pain, and it usually occurs in the area prior to the eruption. It has high rate in elderly. It associated with permanent pigmentation changes and scarring. Okay, so the picture below is the common area where the shingle will develop and the pattern of the rash. So this is the characteristic of the shingles rash. Okay, so for complication, the most common complication is neuralgic pain. However, it is rare in childhood, and it is very severe and debilitating. That it can affect daily activity, life, or the patient. The second one is herpes zoster ophthalmicus. It is sight-threatening. It occurs when the shingles has affected the trigeminal nerve, causing lesion around the eyes. It can cause conjunctivitis, keratitis, glaucoma, retinitis, and for long-term complication, it can result in vision loss. And then for herpes zoster oticus, it can infect outer, middle, and inner ear, and it can also cause hearing loss. If associated with facial paralysis because shingles has infected the facial nerve, then it can result in Ramsay-Hunt syndrome. And then for disseminated disease, it can disseminate to other organs, causing accepted meningitis, pneumonia, and the worst is death. Okay, for management, usually when the acute eruptive phase occurs within the 72 hours, we can initiate antiviral to accelerate the cutaneous healing. But if it occurs for more than 72 hours, we just give if we see a new lesion is developed. Because usually, if we still give, it gives a little benefit because it will resolve spontaneously. And then if we want to give in adult, we can give oral paclitaxel or varicella due to greater oral bioavailability. And then children, we can give acecloprid. For the neurology complication, we can give analgesics. And we can recommend recombinant zoster vaccine, usually in more than 50 years old patients. Okay, so that's all from me.
Okay, next presenter. Siapa presenter last kali?
It's me.
Siapa? Faiz.
Faiz. Yep.
Tapi apa?
Three. Okay.
Okay lah.
Assalamualaikum warahmatullahi wabarakatuh. Sorry. Assalamualaikum warahmatullahi wabarakatuh. Once again, my name is Faiz Imran bin Abdul Hadi. I'll be talking about hand-foot-mouth disease. Now, hand-foot-mouth disease is characterized by rapidly ulcerating vesicles. You can see these are the vesicles. They are present usually in the mouth or usually in the skin, particularly in the hands, feet, and outside the mouth. The causative organisms are Coxsackie virus A16 or enterovirus 71. These are the common ones. The less common ones are listed down here, but usually these are the common ones at the top, especially enterovirus. You should take note of this. I'll explain about it later. But what you need to know is vesicles, oral vesicles in the mouth, hands, feet. Next, epidemiology. This usually occurs around children and infants, kids basically. Usually they are less than 10 years old, especially the ones less than 5 years old. They are prone to get this because they don't have the good hygiene practice is not there. Incubation period is usually 3 to 5 days. And yes, there's been reported outbreaks in Malaysia. It is endemic in Malaysia, especially this EV71. This one causes a lot of complications. I'll brief about that later. But when it comes to the HFMD in hand-foot-mouth disease, what happens basically is that it's usually a fecal oral transmission. And what do I mean by fecal oral? It usually means that you can come in mechanical contact with person. You can come in contact with a contaminated object, or they could also come in respiratory droplets that will eventually come and infect you. And this is the pathophysiology, basically. What happens that you get infected, it goes to your lymphoid tissues, and you'll get viremia, which can either result in clearance or complications. This is a simplified one. This is the original one. I won't go into this. Yeah, okay. So once again, transmission, it is very contagious, especially during the first week after you've contacted it. The virus will, just because the lesion on your hands and feet are not there, doesn't mean it won't be there. You will still be very infectious. So yeah, once again, what is the infective thing? It's saliva, sputum, fluid from vesicles, and also your feces, because it's an enterovirus. Physical contact and droplets, that's how the method it spreads. Now for presentation, usually the child will come with lesions, but mostly there's also sore throat, loss of appetite, because it's painful when they are eating. So when there is sore throat, usually you'd find that in children who can't speak yet, they won't eat much. And children who can speak, they will tell you that the process of eating is quite painful. And so again, there are two lesions, exanthum and inanthum. Exanthum, vesicular lesions on your palms, usually soles of the feet, and mouth. Not inside the mouth, but around the mouth. They can also be around the buttocks, knees, and elbows, and usually they vary in size, but this is exanthum. Now the second kind of lesion is inanthum, which is also usually vesicular lesions, but inside the oral cavity. And they're usually slightly a bit smaller. These are the three main things you should know: the loss of sore throat, exanthum, and inanthum. Also, they can present with prodromal symptoms such as fever. Usually, they can be there. They can present with fever. Sometimes they don't present with fever. But some other symptoms you can find is that these: malaise, headache, abdominal pain, and diarrhea. Also, do note that if you're still wondering about how a vesicle looks like, usually these lesions, they come as papules, usually flat, and then eventually they will progress into vesicles. The vesicles contain the fluid, and the fluid is usually turbid, clear or turbid. They are usually painless, though some sources say they are painful, and they usually resolve within 7 to 10 days. Next. Oh, I won't go through much of this, but what you need to know is that enterovirus 71 is usually the one that comes with all these complications. Usually when you have a HFMD, you go to stage 1, full stop. It just stops there. But sometimes it can involve the CNS, and when it does involve the CNS, you can have aseptic meningitis, encephalitis, poliomyelitis, all these diseases. And you can also note that there are these signs that present. And what that does is that eventually lead to, when there is CNS involvement, there is autonomic nervous system dysregulation, and that can eventually lead to cardiopulmonary failure. And finally, the last stage, you recover. And so, yeah, this is what I was talking about. Usually, this is stage 1 within the green box. But then when there is complications, you can reach here, CNS involvement. And after CNS involvement, you have the autonomic nervous system involvement. And then you have your complications. Also, do note that there is a more severe version. I'm just going to brief through this. Usually the fever, again, is less than 38.3 degrees. But in Coxsackie virus A6, which is relatively new, not new, discovered in 2008, but it is quite notable that the symptoms are more substantial. Usually the fever is higher. The lesions can distribute among the buttocks, groin, perineum. The lesions, usually they are vesicles, but when it comes to this virus, when it gets worse, a vesicle can turn into a bulla, which is a larger version of a vesicle. And they can last longer as well. Usually the lesions resolve within 7 to 10 days. This one can reach 12 days. And they also have complications after the presentation of the disease, namely palmoplantar discombination and nail dystrophy. So when you want to diagnose HFMD, usually it is diagnosed clinically. Again, you just observe the signs and symptoms, which again, enanthem, exanthem, and sore throat or painful. And you also have differential diagnosis. But these ones, the first three I've labeled down here, usually this one comes with oral lesions, which is enanthem. The lesions will only present inside the mouth, and they are substantially more painful. Yeah, they are more painful. So do note that enanthem and exanthem in HFMD, you can have both, but you can also have one without the other. So when HFMD presents with only enanthem, then it's quite hard to differentiate between HFMD with herpangina, herpetic gingivostomatitis, and aphthous ulcers. Aside from they are very painful, and you can look into those diseases about their associated symptoms to make the differential diagnosis. And varicella, not really. It can be quite similar, but usually varicella, the lesions are more they're not painful. They are itchy. Yeah, they are pruritic. Chickenpox, these are exanthem. The top three, enanthem. And also, if you find that the lesions are not multiple, they are singular, it's quite hard to diagnose. You can do a RT-PCR using the throat, rectal, and vesicle swabs from the skin. Management. it's usually symptomatic treatment. You can easily just fix it usually with hydration, unless the child does not tolerate oral intake. Then obviously you need to have a consultation with a doctor. But yeah, usually treatment is symptomatic. You should educate the patient, you should educate the child and the patient, which is the child, and the parents about hygiene. And also I've read that if the pain is severe, then you can administer acetaminophen or ibuprofen, depending on their weight. Yeah. They might come with complications, and when that does come, of course, you have to consult with hospitalize the child. Usually they present with hyperpyrexia, or if you have any suspicions of neurological or cardiopulmonary complications, or basically if the child has inadequate family or social support, then you might need help. And one of my slides missing. Okay, never mind. But yeah, it's basically a conclusion lah. I just want to mention that wash your hands, maintain good hygiene, and if your child is sick, then don't send them to the daycare. But yeah, just remember HFMD, enanthum, exanthum, sore throat.
You ada lecture COVID-19 tak? Tak ada lagi ya?
Lecture about?
COVID-19. Dia ada pergi, tak ada lagi?
Belum.
Mungkin next group kena buat start di COVID-19. Taklah. Okay. Ada apa lagi? Any question for all presenter? Okay, the first the one that I want you to present, like the first presenter present now. The go through by history tau. Dalam HFM ni banyak history dia you can go through. History of to send to the tadika or ni semua how the outbreak occur, everything semua and then the examination finding, the examination finding, you have to look all those things because your clinical year, you're not focused on theory anymore. The first presenter really go through history, what you're finding in physical or systemic examination, what you're going to find in your disease. That's how you should present. No need so much about the management, no need so much about the complication. Just break out layer only. Because your level is only to recognize the disease. Later on, you nak dipakar ke apa ke, baru you learn about the complex complication of the encephalitis due to epizosters or mumps. Then you can go about that. Your moment is to recognize the disease, and your job is how to recognize disease from history and the physical finding. That's all. It's the job to recognize the disease. You boleh baca dalam buku all about the disease. Dapat clinical teaching is about to recognize the disease, to able to make the diagnosis, how to differentiate between mumps and rubella, how to differentiate between zoster and mumps. That is the clinical teaching, clinical learning. The knowledge, everything you boleh baca, you boleh buka, you punya internet, you boleh buka punya buku, dia tulis semua dalam about the epizosters ke apa ke, you boleh baca je. Tapi when you come to us, what we're going to teach you is to recognize the disease, and then only then you recognize the disease, baru you boleh buat diagnosis, and then you do the management. Kalau tidak, you tak tahu benda apa tu depan mata, you tak recognize the disease. Okay, anything else? That's why AI cannot, you see, because the disease, even HFM, there are many type of presentation now. Not only one typical presentation. They can have a different type of presentation. So something variability di mana AI pun difficult. You need somebody with some hindsight of to know what is this, what possibility of this. Because everything is about possibility. Okay, any questions? Tak ada? Okay, soalan Jumaat dah.
Doctor, don't forget to
Mark.
I was supposed to ask for marks, yeah.
Penting
Basically
dia.
that.
Tak apalah,
You
tak
can
apa.
message me or you can give it now lah.
Ya, yalah, pentingnya markah tu, tak apa. I tulis dalam ni, tu pun tak tahu lagi. Your group apa? Group 3, block 3, dah tulis lah markah semua. Nantilah ni siapa yang jadi head ketua ni? Ketua
Saya,
group.
Doktor.
Siapa Zah bukan? Nanti siapa yang WhatsApp ke I tadi?
Faiz.
That was me.
You ada lagi tak pesan tu? You ada lagi after this?
No.
Seminar dengan I. Habis lah?
Ada. Minggu depan.
Minggu depan lah. Tunggu habis yang that one dulu.
Okay.
Okay. Okay.
Thank you, presenter.
Thank you, Faiz.
Thank you tu.
Thank you.
The up to date tu.
Sempat kau refer.
Sempat tu. Wait, tapi HFMD tak banyak tu. Serius tak banyak. Kat textbook pun tak ada.
Terima kasih.
Baik tu.